Directed temperature control for cardiac arrest with non-shaking rhythm. Definition: sudden cardiac arrest is one of the most important causes of mortality in the world's adult population, and although its incidence of the mortality rate in the country affects several million people per year, with a survival rate low, on average less than 10%. This is due to the damage affected by the etymological cause of the PC itself, as well as post-cardiac arrest syndrome, which consists of a complex set of pathophysiological processes that include brain damage, depression of myocardial function, and injury due to the ischemia systemic reperfusion. Application in nursing. Nursing care, once therapeutic hypothermia has started, is aimed at maintaining temperature, continuous monitoring of vital signs and their registration, tremor prevention, adequate sedation, performing different techniques, administering prescribed treatment, and recognition possible or unwanted side effects, such as signs of infection or bleeding and overheating when necessary. Among the prevention are the control of pneumonia associated with mechanical ventilation, the progression of the head of the bed about 30 grades, aspiration when necessary, obtaining bronchial aspiration for culture, the administration of moisturizing drops in the eyes, skin assessment, and postural changes. Pros and cons. Pros: the use of moderate therapeutic hypothermia may improve the chances of survival with a favorable neurological prognosis in patients who remain in a coma after resuscitation due to cardiac arrest with rhythm without response to electrical cardioversion, a new randomized study indicates. Cons: side effects are immunosuppression, diuresis, aggravates or causes hypovolemia or electrolyte disorders, reduced sensitivity of insulin and its secretion, reduced drug clearance, increased bleeding, and coagulation disorders. Issue applied in Ecuador. Ecuadorian Society of Reanimation Cardiopulmonary, the only institution endorsed in Ecuador to provide safe certificate. In addition, their last training was carried out in the last 2 years, 88.37%. The 73.22% of the surveyed population has a suboptimal level, below 10 points, with an overall average of 8.5 out of the 12, with a standard deviation of 1.86. The highest score is the evaluation of theoretical knowledge was obtained by the rotating interns of medicine with an average score of 8.95 points. Conclusion: among patients with coma who have been resuscitated from cardiac arrest with non-shockable rhythm, moderate therapeutic hypothermia, percentage of patients who survive with a favorable neurologic outcome at day 90 than was observed with targeted normothermia.
Cardiac arrest has a very high mortality rate, and it's due to a variety of reasons. The brain starts to undergo a degeneration, basically a self-destruction, where certain chemical processes start to take place, which accelerates cell death. From the time of arrest to the time you reestablish that circulation is what determines your survivability. By starting hypothermia. By reducing the body's core temperature, you actually stop the internal injury process that takes place on a chemical basis. How you institute hypothermia can vary. The main goal is to try to drop that temperature down to about 32 degrees Celsius within about 3 to 6 hours of the time of the arrest. That's your magic window of achieving that hypothermia. You happen to be picked up by an ambulance who is equipped and educated. A hypothermic cooling blanket could be applied. Ice packs placed into the high circulation areas, the axilla, the underarms, the groins, even around the head. Once you're in the hospital, we have some devices that are more formal or sophisticated in cooling blankets, and then another device that's actually inserted into the main vein of the abdomen that exchanges heat internally very aggressively. So we will also institute other sedative drugs to kind of calm the brain's actions, and also muscle paralytics, paralyzing drugs to prevent shivering, which is a natural response, but that consumes oxygen, so you don't want that taking place. So in addition to the natural coma that the patient's in, the drugs will help, blunt any feeling of discomfort or, that you're actually cold. Therapeutic hypothermia has not been widely adopted. It's one of these unusual therapies in our world, which we see often with a lot of novel therapies. It's been around and accepted for almost a decade, but has been slow to evolve into common practice. And it's one of the things that we're dealing with from a medical education standpoint, is to get this therapy out to the public and get it instituted in a timely manner.
Therapeutic hypothermia is medically controlled reduction in body temperature. We use it as a therapy for patients who have had a cardiac arrest. Many times that cardiac arrest is related to a heart attack. During a period of cardiac arrest, there's no blood flow to the brain, and this causes an injury. If the heart can be restarted and blood flow is reestablished, another injury occurs. This reperfusion injury is temperature sensitive, meaning that if we can lower the body's temperature during a period of reperfusion, the injury that occurs after a cardiac arrest can be reduced. If someone has had a cardiac arrest and they remain unconscious, they likely have had an injury to the brain and they are a candidate for therapeutic hypothermia. The program is done through Lifeguard and our Heart Alert program for patients who remain unconscious after a cardiac arrest. We begin the cooling process during transfer, bringing the patient's temperature from 98 degrees, which is normal, down to 91 degrees. Using a computerized cooling system, we hold their temperature at 91 degrees for about 24 hours, and then rewarm them over a day or a day and a half. There are about 300,000 out-of-hospital cardiac arrests in the United States every year. Up until this point, survival has been very low. It's been in about the 5 to 15% range. Using therapeutic hypothermia now, 1 in 5 patients who wouldn't have survived are now surviving. The most important thing you can do if you witness someone who's had a cardiac arrest is to initiate CPR. CPR on the scene by a bystander dramatically improves the possibility of a patient surviving a cardiac arrest. Classes for CPR are offered through the American Heart Association and the American Red Cross, and they are regionally available for anyone who is interested.
When the heart decides to not function correctly and we need to do CPR in order to get it back beating normally, we have decreased blood flow to the brain. And that's when people become anoxic. They don't have enough blood flow to the brain, and it can adversely affect their brain function forever. So by using therapeutic hypothermia, we are slowing all that process down, slowing down the metabolism for a full 24 hours, and then rewarming slowly to allow the brain to restart and hopefully come back to its normal functioning state. We try to get them cooled rapidly within 4 to 6 hours after they've had return of spontaneous circulation. That's the first phase, which is the induction, which goes very quickly. And then the maintenance phase is the second phase, and that usually lasts 24 hours. We do keep somebody chilled at 33 degrees Celsius for 24 hours. Following that, we start a 16 to 20 hour rewarming phase. We rewarm slowly because that seems to help the brain slowly recover after it was without oxygen, which all was involved with the cardiac arrest. If we receive a patient from a different unit in the institution or from outside the institution, routinely they have already been started with a little bit of cooling down by having ice packs placed under their arms, up around their neck. We also give 2 liters of ice saline over 30-minute time frame, either through a central line or through an IV line. We apply the pads, and there are 4 pads that are placed on every single patient. We have 2 pads that are placed on the upper torso. It goes from the spinal column in the back and wraps around the front. Then we also have 2 pads that are applied on the patient's thighs. If the individual has a rather large abdomen, we want to try to cover as much skin as possible to cool as rapidly as possible. So we do have a universal pad that we can use as well on somebody with a rather large abdomen. Those pads then are connected into the Arctic Sun machine. We do turn the Arctic Sun machine on, and we can set it for hypothermia. And right away, we will start having chilled water moving into the pads, and it's a constant fluctuation and moving. It should be around 33 degrees once the patient reaches its maintenance therapy to maintain them at 33 degrees for 24 hours. Once we have a patient back up to 37 degrees Celsius or 98.6 degrees Fahrenheit, the recovery phase then really starts for the individual. We have seen a variety of success stories through somebody waking up and responding to our request soon after we have them warmed. We have had individuals 2 weeks out that, not that we were losing hope, but it was really a struggle because we weren't seeing a lot of interaction, and suddenly people will open up their eyes and they do respond to our requests. So it's very individualized.